Welcome to the Health Information and the Law Perspectives from the Field interview series. Today we are speaking with Dr. Robert Berenson, Fellow at the Urban Institute and Board Certified Internist. Welcome, Bob. Thank you so much for joining us today. Would you please tell us a little bit about your work and how it is related to healthcare delivery, quality, and payment?
Yeah, no, that's what I do. I work on healthcare quality, delivery, and payment. I practiced medicine for 20 years, but then made the move into policy, and so I spend most of my time analyzing and making recommendations about new payment models, new organizational delivery models, expressing concerns about overly optimistic use of performance measures on quality. But that's what I do, is get involved. My major focus is on Medicare, because I spent a number of years at CMS in charge of payment policy in Medicare, but a lot of my work extends into private payers and to some extent Medicaid as well.
Wonderful. So you mentioned a lot of the new reforms and efforts working to improve healthcare delivery and payment systems. What do you see as some of the most promising efforts to improve healthcare delivery and payment reform?
Well, I think the efforts around setting up accountable care organizations, having physicians with or without hospitals taking responsibility for quality and prudent spending, I think is a very promising development. I do have some concerns that we're not approaching it with the right payment approach, but that gets down into the details. But basically getting physicians to move from just generating services based on fee schedules to actually doing population-based health, meaning trying to preserve and improve the health of the population for which they're responsible for, I think offers great promise.
As a follow-up to that question, you mentioned moving physicians from a fee-based schedule to more of a population health perspective. What do you think are some of the tools that can help physicians move in that direction?
Well, there are tools like electronic health records, like more data about performance, but ultimately I think it's about culture and leadership. I was actually involved as a private physician doing population-based payment 25 years ago, and we didn't have some of the fancy stuff, the tools, I guess we'd call them, that we have today, and we were able to do it differently. So I actually think getting financial incentives improved and having a commitment to doing things differently is a good part of what needs to happen. The tools become mechanisms to achieve it.
So as we know, there have been incentives for using electronic health records and other forms of health information technology, mainly to support providers and payers in sharing information across the care continuum. Do you think continuing to move down that path of enabling providers to share information more broadly within a care team or even externally to a care team will continue to help move towards a more population health-based perspective of healthcare delivery?
Well, I think so, but I think people ignore one of the major obstacles to that, which is that for the most part, and I've heard, since I don't practice, I'm not sort of daily involved with electronic health records, but people tell me that the vendors have developed software that is so oriented to the documentation requirements for payment under fee-for-service that the real potential of electronic health records are being missed. And here I'm not referring as much to information exchange as the records themselves, the electronic software not emphasizing enough decision support, registry functions, those kinds of things. It's oriented very much into just documentation for the purposes of getting a high level of office visit payment. I think that's been missed as an obstacle to the full implementation of electronic health records. It's become sort of a data dump with lots of cut and paste from previous encounters just to justify coding. And I've written about this, and yet it doesn't get much attention. But I basically agree with you that there's a real potential of information exchange. There I would say it's necessary but not sufficient. I mean, there have been estimates of savings that would accrue from reducing redundancy of tests and imaging and minor procedures. But that redundancy will only disappear if we had new payment models that would give physicians and other clinicians incentives to reduce the redundancy. So the electronic health record and information exchange, if properly used, would provide the information, but in a fee-for-service system, there's no reason to reduce that redundancy. So to just repeat the point is, I think the electronic health record and information exchange is necessary but not sufficient to change physician behavior, or I should say clinician behavior.
So it sounds like from your perspective, two of the significant barriers to achieving a more population health focused perspective of care delivery as well as payment reform are the fact that the electronic health record and perhaps other health information technology solutions aren't necessarily geared towards true care delivery transformation, but more oriented towards the current payment system, which then acts as an additional barrier to truly achieving payment reform.
Yep, I think that's exactly right.
And do you think there are other barriers to achieving these reforms that we've talked about, or do you think these are sort of the main two primary barriers that we really need to overcome?
Well, I mean, there's a related barrier that we haven't talked about, which is taking my premise that the real potential lies in accountable care organizations built on advanced or primary care, which is sometimes called the patient-centered medical homes. Mm-hmm. The danger is that instead of achieving efficiency, reducing costs, improving quality, and passing that back to consumers in the form of reduced premiums, that those integrated entities decide to keep the savings for themselves, and by being able to achieve market power to raise prices. So it could well be that the ACO might be more efficient. There are, at least theoretically, some economies of scale, better access to capital to get better electronic health records and other technologies. But they also have the ability to raise prices on payers, and we've seen evidence of that. We've seen consolidation in the provider market horizontally, with hospitals forming mega hospital systems, and now through ACOs we're seeing vertical integration, with doctors becoming either employees of hospitals or being part of joint ventures with hospitals. And unfortunately, as long as we have a predominantly fee-for-service system, that results in raising prices and, in fact, raising the cost of health care rather than reducing it. So we have to move towards integrated care, but we also have to address this concern about market power that consolidation and integration produce.
So it sounds like what you're saying is that the potential for market consolidation that may be happening through the formation of some of these patient-centered medical homes, accountable care organizations where physicians are coming together, and perhaps taking advantage of some of the incentives that are available for use of electronic health records, as well as these new delivery care models, that there are some unintended consequences of that, mainly raising prices on the consumer that aren't being passed through to the consumer. Is that correct? Yeah,
I think so. I'm less concerned about medical homes, that primary care practices would have that kind of market power, as I am about integrated hospital physician organizations or single specialty groups that get market power. But yeah, that's the general concern, is that this is an unanticipated policy consequence. I'm a little suspicious that some of the hospitals that are actually employing physicians in the name of forming integrated care to do population health and be more efficient, that's just sort of the public presentation of what they're doing, and in fact what they're really doing is just taking advantage of the flaws in the rules around fee-for-service. So one of the examples in Medicare and for private payers is that a hospital gets paid about twice as much for the identical service performed in the outpatient department as it would be paid for in a physician's office. So in some cases you have the physician who used to be an independent practice, or the physician's practice that used to be independent now has a plaque on its door saying it's part of the outpatient department. It's in the same location. It's got the same personnel. The services are identical. It's just that they get twice as much money because there's a facility fee associated with it. So it is hard and challenging to figure out which hospitals' systems are really developing new models like accountable care organizations with integration to actually change their business practices, change their business model, and which ones are doing it really to just take advantage of flaws in fee-for-service.
Thinking in addition to the payment mechanisms here, particularly fee-for-service, with the formation of accountable care organizations and other integrated forms of care, one of the benefits often can be easier sharing of patient information or access to patient information across the care team. However, on the flip side, when you're thinking from a market perspective, we've seen instances where actually information has been hoarded to maintain market share or patient share, so to speak. Is that something that you're encountering in the work that you've been doing as well, seeing the use of information or hoarding of information as a piece of market power as well?
That's interesting. No, I'm not aware of that phenomenon, but I guess I don't find it surprising. I do find surprising that some of the systems, the IT systems, don't talk to each other even when they are from the same vendor. There doesn't seem to be a commitment as we've proceeded with meaningful use to actually get information exchange. But the part about hoarding is not one that I'm aware of.
So going back to the question dealing with the impact of market consolidation as sort of a consequence of the multitude of incentives that are available, when you're thinking about changes to the fee-for-service payment system, the underlying payment system, what do you think are some of the best solutions to address the payment mechanism that might break down some of these concerns with market consolidation?
This does get into the sort of nitty-gritty of the new payment models. If in fact one moved to a payment model that was akin to what used to be called capitation, that's become a dirty word, so we don't use it much anymore, but the equivalent of that is, let's say, a percentage of premium deal, where the provider system gets a percentage of the health plan's premium that they're actually marketing in the marketplace. Then there's actually a counter incentive against raising prices. That premium is established as a community-wide premium. Any healthcare system that demands higher prices for their services in that thing, it would be self-defeating because all they're getting is a percentage of that premium. And so that is the kind of payment mechanism that could address pricing. Clearly, the systems that are already getting high prices will resist that. They would much rather have what's currently being used in Medicare and amongst most private payers, which is comparing spending to your historic spend. In other words, taking your historic spending, trending it forward by some inflation factor, and then comparing whether your new spending is more or less than that target. and that essentially builds in the pricing distortions that already exist in the marketplace. And the point I would want to emphasize here, which I haven't done so far, is that there are extraordinary pricing differentials that are basically unjustified. And this was well documented by the Attorney General of Massachusetts report from 2011, which found that hospital prices varied 150% from each other, based not on the quality of care produced, not by the teaching mission, whether there was a teaching mission, not by socioeconomic factors of the patients, but simply as a function of market power. And so some hospitals were getting Medicare or a little more than Medicare as their rates, and others were getting 2 times Medicare or even more than that. There has recently been documentation of some hospitals that are getting 500% of Medicare, and what's the justification for that? It's because they can. It's a market negotiation between the hospital system and the health plan, and in some situations the health plan has no alternative but to use that particular hospital system or healthcare system, and the result is paying extraordinary high prices. So I guess my basic point is that this has not been an issue that's gotten an awful lot of attention, and it deserves it. One could ask the question whether not-for-profit hospitals deserve their not-for-profit status if, in fact, they have, if they're able to negotiate payment rates that are exorbitant like that and pay their executives huge salaries. It's not clear what the social benefit is, but that's a whole different issue that I think one could look at.
So you mentioned the Massachusetts Attorney General report. It was obviously involved greater transparency of price information. There are obviously a lot of efforts underway to increase transparency of price information as well as quality information, and some of these efforts are supported by exchange of health information to yield this information. Do you think these efforts to continue to increase the transparency around price information and quality of care information will be a benefit, or do you think they might have some unintended consequences related to, again, market conditions that ultimately are driving up prices?
Yeah, no, I think both. One of the real values of that transparency is to shine a spotlight on the issue. I think it is embarrassing to a hospital system if that kind of data reveals outrageously high prices at a time when people's premiums are still rising significantly. I think that is useful. At the same time, in terms of actually affecting behavior, there's some reason to believe that when you produce the prices, when you publicly release every hospital's prices, I'm picking on hospitals because this is the easiest area to produce prices, and hospitals do represent a significant percentage of health spending. When you produce everyone's prices, the hospitals that have been relatively low priced look and say, I want what that guy's got. And in fact, it can have a perverse effect to increase prices. And indeed, the Federal Trade Commission says that in some circumstances, not just in healthcare, but across other sectors of the economy, transparency of prices can be anti-competitive. So it's actually something of a complicated topic. I still think that the pressure for transparency is such that we will go there, and then I think the question is, how do we deal with those entities whose prices are extraordinarily high? And there are probably market-based and regulatory approaches to deal with that. On the quality side, again, generally I'm in favor of transparency of information. My concern is that in many important areas of health delivery, we don't have good measures of quality. And so I've been concerned and have written about my concern about taking measures that we do have and exaggerating their importance. The most absurd is what's now current law, in which by 2017 CMS, the Centers for Medicare and Medicaid Services, will be by law obligated to provide a value modifier, an index of every physician's value. They're supposed to consider both quality and spending to determine a value index for every physician. Well, it's crazy. We don't have measures that can do that. CMS has to pick a handful of measures, some of which have very little to do with a physician's overall quality, and somehow attribute spending through the whole system to an individual physician and come up with this value index. It's quality measurement run amok. I think there are some good measures, and I'm all for publishing those measures, but I have great concerns about overdoing or not recognizing the limitations of the quality measures that we now have. In very many important areas, we do not have good measures of quality, and so the concern is that we're going to use some marginally important ones to fill in the gaps, and that will be very misleading.
Wonderful. Well, we very much appreciate your expertise and perspectives that you've shared with us today. Thank you.